Everybody. Welcome you all to the CRC webinar. We are going to be discussing on PMOs. We have eminent faculty panel. So I would like to welcome you all. I would like to have the prayer song, Arun, and formally started. Thank you, Arun. I request Shobha ma'am to give the welcome address. Thank you, Shobha ma'am.
Secretary General of Kasoga.
Secretary
Thank
General.
you, Srimati, for. Hello. Am I audible, Srimati?
Yes, ma'am. Yes, ma'am. Yes, ma'am. Sorry,
Hello.
Secretary General
Yeah.
to
Thank
give the welcome address.
you so
Sorry,
much.
ma'am. It just feels like Shobha, ma'am. So it didn't feel like introduce you like that. Sorry, ma'am. My apologies. Kasoga, Secretary General, Vice President.
This is a platform where all of us
Yes,
know
ma'am.
each other. I can go ahead. Yeah. So this is a beautiful evening indeed today. That Kasoga has decided to have a discussion on the PMOS, the new terminology, polyendocrine metabolic ovarian syndrome, and I Chandrika, especially Dr. Raman for being. Well, the world has now decided to come to a consensus on this highly complex disorder, which was PCOS for us. It will be a long time before we finally metamorphose into PMOS and go forward with that. But today, at least, the clinical perspectives will become clear. And what we need to change in practice will become clear. So all the very best to you, and my namaskars to Hiremat sir and Nagraj sir, and my hearty compliments and congratulations to our beloved President Rajashri Paladi, because I think she seems to be the golden lady. Everything she is touching is becoming a success, and so also is this evening. And with that, over to you, Srimati. Over to you. Thank you very much for having me.
Thank you, ma'am.
Over to you.
Thank you. I would like to request our Kosoka President of beloved Rashri, ma'am, to give a welcome address. Thank you, ma'am.
My pranams to everybody and respects to the seniors on this platform, Dr. Jyotika Desai ma'am. It's such a pleasure to have you here on this platform, and I'm addressing you for the first time today on this platform. It's always, we look up to the knowledge and the influence that you have on the academic circles, and it's indeed an honor for us to have you here. My respects to Dr. M.G. Hiramat sir, our patron, because of whom we stand tall today, and Kasoga has an impact. And my heartiest pranams to Dr. Anantaraman Ramakrishnan. I'm seeing you for the first time, sir, but I'm glad that we are meeting on this platform. Welcome to Dr. Chandrika Anand, and of course, my dear Rashmi. She's an angel in our basket. So, also Dr. Srimati Raman. Let me take this opportunity to say that and to put it on record that Srimati and Rashmi are the silent force behind whatever activities we are doing today in Kasoga. Whatever I put forth on the platform, I take their opinion. Is this okay? And then they say yes or no. And depending on that, we go ahead with all the, this is such a mixed bag of intellect and the think tank that we have in Kasoga that it's just, we need to touch the right potential and get the best out of it. So also today's evening and address on PMOS, it's just like a renaming ceremony of the old wine in a new bottle, although everything remains same, and then maybe some new addresses have to be done touching upon the aspects of the metabolic disorders that we are looking up to. So that was a very kind address, Dr. Shobha Gudi ma'am. Yes, with the this is a well-oiled machine now, and then it's very easy to put it on the third or fourth gear wherever we want to take this engine to. And that is what is exactly happening in our webinars and in all our scientific forums. I take this opportunity to also welcome the entire Kasuga family to Manipal University, wherein Udupi is hosting the Yoga Day on the 21st of this month, and also the colposcopy workshop, which will be done in live in Bagalkot on 27th and in Dharwad SDM on 28th. So such are the intense activities which are going on silently everywhere, and everybody is taking a notice of it and making the best use of it. And this is exactly what we wanted, that percolate into all societies at all level and bring in the every touch upon every aspect of what we can do for the best. And so also the first Tarunya program has flagged off on the 8th of this month, started addressing the girls about the menstrual health and hygiene, and it's being circulated to all the societies, and I request every members to make the best use of these modules that we have for the Tarunya, that is for the adolescent health program. More to come in the kitty, and then yes, I would not take much time and intervene between the excellent speakers that we have today, and I'm sure that the amount of information and the new recipients, the new recipes that we have for the protocols of management is there to discuss. Over to you, Dr. Srimati. Thank you so much for coming up with this beautiful program and touching upon a topic which was just needed for the moment. I know when the whole world is talking of PMOS and we cannot be stuck upon PCOS and be telling PCOS anymore. Thank you so much for having this.
Thank you, ma'am. Thank you. You're indeed very kind. I think Rashmi, I can probably take Rashmi also along and say we are really humbled. We are really little pawns in the big, in the big picture. But really, thanks for having us along and taking us along with you, ma'am. Thank you very much. We're really honored and privileged and humbled. That's all I can say, ma'am. And of course, Jyotika, ma'am. Anyway, can we have the CV, Arun, please? Jyotika, ma'am, yes, ma'am. As you rightly said, she is the woman behind all of us, all of it, definitely in CRC. Ma'am has been hand holding me for the last year in CRC. I mean, of course, even before as well in BSOG. So I'm really grateful to ma'am for all her mentorship, for all her guidance, for everything, ma'am. I don't know what else I can tell about you. So ma'am is ma'am, senior consultant, PR Desai Hospital. Whatever there in the CV is, I don't think means anything at all. But definitely, ma'am has achieved Lifetime Achievement Award, Unsung Hero Award. But you're really a hero, ma'am, heroine beyond words. So really bow to you and thank you for being with me all the way throughout in BSOG career, ma'am. Thank you, ma'am. As Rashmi ma'am said, I want to place it on record all that you've done to me, ma'am. So thank you.
No, not at all.
Thank you.
But you are embarrassing.
Next slide, please, Arun. Of course, we are very privileged to have Rashmi giving the first talk. She's a very good friend of mine. She's a senior consultant. She's, I mean, she's all in all, she's a beauty queen. She's into everything, not just academics. She's an all-round personality. She does lots of MRCOG teaching, training. She's a chairperson of the quiz committee, Kosoga. So it's really great privilege to have you, Rashmi, on board with us. And also the other faculties, CV, next slide, please, Arun. The next, yeah. And also, I would love to invite the other two faculty as well. Dr. Chandrika Anand, ma'am, thank you very much for joining us. Madam is part of the Saraswati Gyno World. She's a managing committee member of the PCOS. I'm sure it's going to be renamed shortly to PMOS Society of India. And she's also the South Zone Coordinator of Endocrine Committee Foxy since 2021. She's been the top 10 gynecologists of the South India and the Outlook Survey. And her areas of interest are particularly PCOS. And that's the reason Jyotika ma'am, in fact, suggested that we have her because it would really be a great, informative discussion which we're going to have today. And of course, she's going to be joined by none other than, the next slide, please. Next slide now. None other than Anantaraman sir, whom we have already introduced, but of course, to formally address sir. Sir is an endocrinologist. He is part of the Magna Center. He is a founder and chief endocrinologist, which has got multiple centers in Tamil Nadu and in Karnataka. He's also part of Chinmaya Mission Hospital, Motherhood Hospital, and Cloudline, Bellandur. He's a co-investigator and PI in several RCTs, and he's published lots of original articles, and he's been organizing the annual Magna Endocrine conference, Endocrine conference, and has been a faculty in many of your OBG conferences, of course, endocrinology conferences. But what we need to say is many of our OBG conferences, and he's also going to join in our RCOG South Zone conference as well. It's indeed a great privilege to have you with us, and thank you very much to all the faculty for joining us today. So with this, I would like to invite Rashmi to give our talk on PMOs. What is the new update in it? What is in the name?
Thank you, ma'am. Thank you so much, Srimati ma'am, Rajeshri madam, and everybody on board here for providing the opportunity. I'll start sharing my screen. Is the screen visible, madam?
Not yet?
Start.
Yeah.
Slideshow. Agatha,
Yes,
slideshow.
ma'am. Okay, ma'am. So to begin with, what is in the name? I think most of it we have seen that everything comes out in the name also. And why there was a change from PCOS to PMOS. So polyendocrine metabolic ovarian syndrome. It is the new name for polycystic ovarian syndrome. And I'm very proud to say that our beloved member, Dr. Madhuri Patil ma'am, she was involved in this Lancet publication of polyendocrine metabolic ovarian syndrome, which is the new name, which was a multi-step global consensus process. Now, this mainly focused that why there was a need for the change of name to be there, because the term PCOS was inaccurate. It was implying a lot of pathological ovarian cyst. It gave a lot of misconception to the patient that she had some problematic ovaries, and obscuring all the diverse endocrine and metabolic features that it carried along. It also contributed to delayed diagnosis, a fragmented care, lot of stigma associated with that, and curtailing research and policy framing also. Now, this was rigorously implemented. The global consensus was done by engaging patients, which was very important. A multidisciplinary health professionals were involved. A lot of organizations across the world came together. And then, depending on the surveys that was conducted, it was agreed upon that polyendocrine metabolic ovarian syndrome is a proper terminology for this diverse features of this condition. It was a coordinated implementation, and this is underway in health systems, research institutes, all the funding body, and definitely this will come with the ICD coding. It is going to take some time, I would say.
Rashmi, you're frozen.
Rashmi?
Rashmi, stop your video. Maybe then you can continue talking.
I think she's not able to hear us.
Call her and see what's happening.
I think she's just logged off, ma'am. I'm calling her.
Calling her? Okay, fine.
She's joining, ma'am. Yeah. You're
Rashmi
muted,
ma'am, you're
Rashmi. You're
muted.
muted.
Rashmi ma'am,
Rashmi,
you're
you're
muted.
muted.
Rashmi, you're muted.
Yes. Am I audible, madam? Sorry.
Yeah, yeah.
So the nomenclature was important because a lot of people were getting neglected, especially the adolescent group. We had metabolic concerns, we had dermatological concerns, polyendocrinopathies, the ovarian problems, oligo or anovulation, and not to forget the psychological aspects of it, like depression, anxiety, PMS. All these things were correlating. When we were thinking about the PCOS, we saw that it would affect 170 million in their reproductive age group. And we all know the criteria about oligo, anovulation, clinical or biochemical parameters of hyperandrogenemia. and polycystic ovaries, ultrasound, or elevated AMH levels. But when we come to adolescent, the first two criteria are important for them. If we look into a lot of metabolic, reproductive, psychological aspects of it, a longitudinal global study was conducted and 84% respondents endorsed a global consensus process to identify and implement this new name change, along with all the education that they acquired and implementing strategies. We also saw that important societies from global initiatives, they came together in this particular research. And building on the previous survey results, this was co-designed and disseminated, and international consensus workshops were conducted as well. We could see that they conducted a structured multi-step global process, which would involve the funding, the governance, and stakeholder engagements. Delphi surveys were conducted across 7,708 previous surveys. All the respondents were included. There were nominal group workshops and marketing communication strategies and analysis were done. Prioritized outcome was done and implementing strategies was brought into 25 and 26. There is a transition that has happened and new surveys was always being conducted between 2017 to 23. They were informed by all the literature review and consultation along with multidisciplinary health professionals and people who were having PCO. Additional naming principles were there because it provided scientific accuracy, the ease of communication, overcoming the stigma and the cultural appropriateness. And then definitely it was changed to PMOS. If we see, patient involvement is a very important factor. So the Verity, which is a UK-based patient charity and advocacy group, was also involved in this, as well as the Australian Health Research Alliance groups. Now, if we look into all the research and implementation, it was co-designed and organizations across various health professionals, including obstetric gynecology, fertility, endocrinology, pediatrics, dermatology, imaging, primary care, nutrition science, and psychology came up to this. We have also seen that it is not sparing the obstetric outcome, be it miscarriage, gestational diabetes, gestational hypertension, preeclampsia, preterm were also affected. And not to forget the cardiovascular diseases that was associated with this. So it was very important that we bring up a proper framework which would involve interdisciplinary team, a primary care or a point of contact, a centered care, which is an accessible care module. We should make sure that the patient empowerment is there, education is provided and prioritized as well. And we have to make sure that there is a self-care across the entire lifespan. If we look into summarizing of all these naming principles, mainly focused on the clinical care research and improved health outcomes, keeping scientific medical accuracy, providing a good clarity and communication, avoidance of stigma, the cultural linguistic appropriateness has to be followed, and feasibility of this implementation should be there so that there is a practical transition that happens in the clinical, in the research and policy environments. There were various stages of global implementation. I would not go into details of this. And if we see what were there exactly that we're looking, more than 86% of all these patients, they have supported the name change. And 76% of the healthcare professionals have also supported the name change. This PMOS, it encompasses a multiple interacting endocrine abnormalities rather than keeping an isolated ovarian disorder only. And meta-analysis of large-scale genomic analysis has been done along with this recent definitive studies. They confirm that PMOS has a polygenic origin across the neuroendocrine, metabolic, and reproductive pathway, which I think our esteemed experts are going to discuss in detail about this. So let us see whether this insulin resistance or it is a low-grade inflammation, adipokine signaling dysfunctions, be it sympathetic nervous system.
Again, she's gone.
Yeah, I'm making some issues with the network.
It's 15 minutes since she started.
Yeah, ma'am. Because you're already in, what is it, 8:25?
25
We
now.
also saw that all these premenopausal things, it has increased odds ratio with the cardiovascular and stroke and myocardial infarctions also. If we look into as such, it is disturbance in the genetic origins, disturbance in the endocrine, paracrine metabolism across all the life stages, which is beyond the reproductive age group. In conclusion, I would like to say this is common yet historically neglected female condition. It is affecting more than 170 million, as I explained before. Therefore, global engagement of people along with the healthcare professional, this name change was important so that it avoids any misleading references to ovarian cyst of other pathology. It accurately reflects the women's condition and involve the multi-system features, and therefore helping us to have a multidisciplinary team approach. Now, the condition which is formally known as, it has been coined as polyendocrine metabolic ovarian syndrome. And we should understand that these implications are including the healthcare system's policy research. However, it may take 3 years for this transition to happen, which is going to be supported across all the implementation strategies. I would say, let us concentrate the shift of focus to the whole body health. Let us focus on prevention. Let us have a multidisciplinary approach, and let us focus on a woman's lifelong health. Thank you so much. And these are certain flyers which I think everybody is circulating. So I also try to create using some chat GPT. A lot of social media influencers have coming up and explaining the name change and other things. So why not doctors? So please do provide authentic information across all social media platforms. Thank you.
Thank you, Rashmi. So, ma'am, shall we start off with the discussion, ma'am? And then maybe as and when the questions come, we can go to the questions, interactions later, ma'am.
Fine.
So, can I request Jyotika ma'am to take over the next part of the scientific session, which is going to be a discussion. So, ma'am is going to be leading the discussion with Chandrika ma'am as well as Anantaraman sir. So, we're looking forward to this exciting discussion, ma'am.
Thank you, Srimati.
Thank you, ma'am.
Thank you. Good evening, friends. We've just heard Rashmi giving us an insight into the change of name from PCOS to PMOS. She's also explained why the change was necessary. Let us delve into the complexities which patients and clinicians may face with the new acronym and its implications. You have already heard we have two experts, Dr. Anantraman, an eminent endocrinologist, and Dr. Chandrikanan, the famous infertility specialist. In fact, I should say a famous PCOS specialist. So here we go. I just request our experts to be brief in their replies. First, now does the name matter? Will not a rose by any other name smell just as sweet? So said Shakespeare. Many clinicians argue that changing the name will not change outcomes. Others believe names influence awareness, diagnosis, and patient behavior. In practical terms, what difference could PMOS make in your clinic tomorrow morning? Chandrika?
Yeah, good evening, all the eminent speakers, and thanks, Kasava, for this wonderful opportunity to discuss what is in our minds. We are not endorsing any society, points. It is what with my experience, and Anant is talking about his experience, and Jyotika ma'am also. All of us, whatever is running in our minds, we are doing it. We are not this is not endorsed by any of the societies. So I feel, ma'am, see, in India, if we see, almost around 65 to 70% of the patients with PCOS go to gynecologists first. Okay, around 10 to 15% go to general practitioners or primary care. Only around 10 to 12% goes to endocrinologists. Around 5 to 8% goes to dermatologists. So even though if it is a multiple endocrine problem, most of the patients end up in a gynecologist. So that is how the name change, how it changes in my clinic tomorrow, is that now it becomes a little easy for me to explain that, why we are doing so many hormone tests to the patient, why are we ordering tests, why are we giving, why are we talking about weight loss in apparently lean PCOS also, why are we talking about a lifestyle, why we are screening for diabetes, why we are doing giving metformin in some cases. All this becomes a little easier for us to explain with the new name change.
What about you? Thank you, Chandrika. You will be spending more time on counseling then, right? That's true. Dr. Anantraman, what is your take on this?
I feel the name change is welcome because, with the earlier name, polycystic ovarian syndrome, so patients used to commonly think that there were very large ovarian cysts in their ovary. This is a very common misconception. Many patients, when they come, they are usually not come with a diagnosis of PCOS. We can diagnose, of course, PCOS clinically based on the history and presentation. But if you point out that the patient has that you may have PCOS, they'll tell that, they've undergone an ultrasound last year and it was normal immediately. So, so then we'll have to explain to them that, what is the sensitivity of the abdominal ultrasound versus transvaginal ultrasound, and ultrasound is not necessary for diagnosis. We can do AMH also. So all these things are there. So the PCOS diagnosis, used to cause some confusion among patients, actually. So regarding the nature of the condition. So we'll have to discuss, and discussing the diagnostic category is always difficult. So if what the disease represents is present in the name of the disease itself, it's easy for patients to understand that they have it. So polyendocrine captures that multiple endocrine abnormalities can be there, such as prolactin increase can be there, testosterone elevation can be there. So metabolic will encompass the fact that there can be, obesity and diabetes and pre-diabetes can be there, and of course hypertension as well. And when it comes to ovarian, so we talk about, anovulation as well as, the polycystic ovarian morphology as well. So it helps us point out easily to the patient. So tomorrow, I think it's easy for us to, explain to the patient actually. So what is it that they're actually having?
I'm sure, Dr. Anantram, the change is going to be a welcome change for you, because you can you can have a carte blanche order all the metabolic tests and all the endocrine tests. Okay. So pouring old wine in a new bottle does not rob it of its properties or its potential. So now we come to what Lancet has mentioned about the stigma. Now, the article mentions that the stigma is less now. I would like my experts to talk about it. PCOS has traditionally carried a stigma related mainly to infertility, of course, and also especially in our country, it can be a very bad stigma, and also for irregular periods, facial hair, perception of femininity, etc. Will PMOS reduce the stigma or simply replace it with added stigma associated with diabetes and metabolic disease? Dr. Anantram, you take it first.
Ma'am, I think awareness is improving among the public regarding this condition. So changing the name is not going to change the stigma. I think the stigma level will be the same. So there is a stigmatization. So when it comes to choosing partners for marriage and other things, though we say, publicly, we are, supportive of people with disease. So my patients with diabetes do have trouble getting married. Type 1 diabetes, definitely there is trouble getting married. And when girls are having irregular cycle, the primary consideration among the lower socioeconomic condition is, if the cycles are not coming, whether she'll be able to get married or not. So this is a very strong social stigma regarding PCOS and diabetes and other metabolic diseases widely. So, but the thing is, the disease nomenclature may not destigmatize. It makes it more easy for us to explain to the patient, I believe. And destigmatization is a very long process. And also, the first stop in destigmatization is make the patient aware and what they can do, and our intervention actually. So, our intervention actually reduces the stigma for the patient.
Dr. Anantram, my question to you was, is the stigma more or is it less?
I think it is the same.
No, in my opinion, it is.
I think it's the same. Yeah.
Let us see what Chandrika has to say. Chandrika, what is your?
Ma'am, I agree with Anand. See, now this PCOS, see, now women having PCOS, girls having PCOS have difficulty in getting married, and they don't want to publicly tell that, when we ask for a Google review, when they do so well, they'll tell, no, we don't want our daughter to say that she has got PCOS in public. So that kind of taboo is there. And once they are married, okay, you have PCOS, you won't conceive, you will have fertility issues. That stigma in the in-laws house was there. That will be lifted. let me be honest. PCO, because of the PMOS, most of the elderlies and the other aunties or whoever generally shame the young girls. They wouldn't, they will be relieved that, okay, now there is nothing wrong with the ovary. So marriage and fertility won't be a challenge. But unfortunately, this the more we talk about metabolic and polyendocrine, little smart aunties and smart uncles or the in-laws, they may start, even the husband may start thinking that, okay, now does this girl she's okay, she has conceived, she has had 2 children with us, but then, she had PMOS some time back. Does it mean that her metabolism is not well, or, she has got some endocrine problems? So I feel it is going to kick in a little later. The
Yes.
stigma is the same or it could be worse, but then initially these girls are now relieved. Okay, fine. I don't have PCOS, I don't have cyst, and my ovary is working well.
Very true.
Ovary working well is a green ticket for marriage and children.
Absolutely. Our people think, that just conceiving is enough. But now with the added metabolic and endocrine part of it, it is going to stigmatize the woman more than less. So I feel that the stigma is going to deepen and we're giving our patients more bone to chew on. In the earlier they were used to only worry about the ovaries. Now they have to also worry about their heart, their kidneys, their liver. Fatty liver is also a problem. Okay. Now let us see a common clinical scenario. A 22-year-old woman presents with irregular periods and hirsutism. Her ultrasound is normal. In fact, she doesn't have polycystic ovarian morphology. She is not obese. Her BMI is 22 kilogram per meter square. And metabolic investigations, meaning thyroid and sugars, all were normal. She asked, if I don't have cysts and I don't have metabolic disease, why do you say I have PMOS? Well, for practical purposes, she has phenotype B. So let me know now. Chandrika first.
Yes,
How
ma'am.
will you explain the diagnosis under the PMOS framework?
This becomes a little challenging, as just now Anand told that, when they show this scan report is normal, but why do I have PCOS? The same question will come that my metabolic profile is normal, why do I still have PMOS? That question is going to come. And I think I am kind of anticipating, Anand, that maybe in 3-4 years, they may redesign the criteria for diagnosis also. Like maybe it is not just the typical 3 criteria of PCOM and hyperandrogenemia and irregular cycles. They may add on obesity, or maybe I have a feeling it is coming up. So in that context, this is a typical challenge of a lean PCOS. Lean girls, they say they are not obese. Why am I? Yeah, why am I like that?
Phenotype B now.
Yes.
When there's nothing, no ovarian polymorphism.
It is difficult to convince them. It is difficult to convince them. But then we need to talk about hyperandrogenemia, hirsutism, and anovulation. We need to talk.
But even if she does not have PCOM and obesity now, we all know that she's not at risk for metabolic syndrome now. She has an 80% risk of having insulin resistance later on.
Absolutely.
Lipedema and abdominal obesity coming on. So she has come as of now at 22 years in the window of opportunity to help her avoid these problems in the future. So counseling and helping her is very important here. Okay, we'll come to another patient now. A worried 19-year-old adolescent. She has been diagnosed with PCOS elsewhere. She comes to you for advice. Now, what is the gamut of your counseling? Will you tell her about all that which is in store for her and make her more worried than she already is? Or you will deliver the bitter truth with a sugar coating? And which name would empower her more, PMOS or PCOS? Anantram, can you take that question?
Ma'am, I think the PMOS is a more appropriate term to explain to patients what all could know what the mechanism of the disease. And regarding your first question, ma'am, you wanted to know, how much I will reveal.
How much?
So I will, I usually confine myself to the next 1 or 2 years, ma'am. So I don't really talk about too much about the future. I don't project too much into the future. I tell even all my patients also never make a 5-year plan like that, because we really don't know what is going to happen after 5 years. So if a patient with diabetes who's newly diagnosed at 30 years, if you tell them that your lifespan will be shortened by 6 years, that's not a correct message actually. So we'll tell them what are the lever. I focus on what the patient can do to improve their condition. what medication can do. I will tell them that typically if we give you metformin, like for example, if there is a lean PCOS or a very not too much of obesity, I'll offer metformin.
We are talking
And
about a 19-year-old adolescent.
yes, ma'am. So if the cycles are irregular, I would prescribe metformin to improve the menstrual cyclicity. If the child has obesity, even we can offer one of the GLP-1 agonists also to reduce the weight actually. So we have much to offer now. We offer, of course, diet and exercise to all of them. So we'll tell them that, when you do all these things, your cycles should improve. If they have hirsutism or acne, we give treatment for that. Anti-androgens we'll give. We'll give oral contraceptive. So we'll talk about the 2-year time window, what kind of improvements you can get in the 2-year time window. I don't focus too much on what may happen after 4 years, 5 years regarding the future fertility and all. I don't usually start the conversation at a younger age. That is my approach because, as time comes, they will come back again and then we will talk to them about all those things later.
Right, Chandrantram. What does Chandrika have to say about it? Would you
Madam, I kind of differ a little bit because see now we are the primary physicians and this is a window of corrections. Most of the adolescents are called at risk of PCOS because we don't have one criteria, so they could be at risk. So what I do, Anant, is see as you told, 19-year-old she's not bothered about fertility. But what is something which is very under addressed is the mental health of these teenagers. So I really look at, talk to them, spend some time with them and give some screening questions, check if she has got depression and anxiety. Default adolescents are having more than 70-80% are having mild to moderate depression and body image issues and binge eating and eating disorders. So I feel as a teenager, I spend more time, madam. Particularly, I interview the parents also separately, because the mother is the one who's holding the kitchen. So for weight reduction, the mother we need to counsel more. So I am actually invested more in adolescent girls because they are the ones who will eventually turn out to get into metabolic syndrome. That is the group where preventive, gynecology helps a lot. So I wouldn't scare them about fertility or cancer, but definitely it's about obesity and worsening of hirsutism and emotional health, and they generally resonate, madam.
So you're not going to tell them that if they continue on this life, the way they're going on, she'll get diabetes, she can get fatty liver.
Yeah,
Yes.
I mean, I do sensitize in the sense that you will get into some metabolic issues. You could get insulin. See, insulin resistance is better to cure than diabetes.
Very true. But unless we sort of make them aware that they have to follow very strict lifestyle modifications, they're going to end up wherever PCOS or PMOS is going to lead them. So they have to be made aware a little bit of, what can possibly happen. Now, the problem here is how are we medico-legally safe if we don't tell them what the future can hold for them? See,
Madam, actually, I give a booklet on PCOS to all my patients. Whoever comes into my patient, I made a booklet, where explaining how, what are the reasons and why they got it and what is the use of cosmetics, simple things, easily understandable. And I give a booklet. So I feel creating awareness is very important. It is a voluntary thing, but I don't think so medico-legally because, madam, even suppose a diabetes patient comes, as Anantram told, we can't be talking about retinopathy in their first visit. We need to tell them, make them aware of complications, but not everything at the first shot. So I don't think so, that onus is on us.
Into the picture, but very soon it may come into the picture. Apart from this, the other thing here, the same line I wanted to discuss, insurance agencies may have a higher premium because now it is PMOS. So they can have metabolic problems, diabetes, hypothyroidism, hyperprolactinemia, name it. What do you say, Dr. Anantraman? Do you think insurance agencies also will have a higher premium for PMOS compared to PCOS?
I doubt whether because it's the same disorder, ma'am, just a change of nomenclature. I don't think they will charge more for.
To the lay person, it makes a big difference. Get it? Anyway, these are all things which we need to think about, huh? So, let's talk about lean PCOS then. Now, women diagnosed as lean PCOS. We all know PCOS is total is always associated with obesity. So one criticism of PMOS is that it may overemphasize metabolism. Could women with lean phenotypes feel excluded or misunderstood under the new terminology? Can you take that, Anantram?
Yeah. We do a body composition analysis for almost all the patients who come into our clinic. So whenever I get a girl with irregular cycles and PCOS like picture, I always look at the body composition analysis. Thanks to our obesity practice, we have that set up in our clinic, and I'm doing it for almost all patients. So getting that done is very easy. I think it's now widely available in many places, and that will tell us how much is the visceral fat and whether the visceral fat is excessive or not. So that will help explain the patient that the body fat percentage is more related to the muscle mass. And some girls may have a very less muscle mass. They may have sarcopenia. In fact, they may be very lean, and the visceral fat may also be less, but they may have sarcopenia. And improving the sarcopenia will improve the insulin resistance and result in improvement in the menstrual cyclicity also. So it helps us open the dialogue between muscle function, fat percentage, muscle mass, and the PCOS pathology itself.
I agree with you that one report is enough to shake them up when they see the fat percentage which is there in the abdomen. So do you think people with lean PCOS have fewer metabolic problems compared to obese PCOS?
Ma'am, I feel they have equal amount of metabolic problems. It's not
Absolutely.
less actually.
Yes.
So in fact, what I feel is that in my clinical practice of diabetes itself, patients with lean diabetes or just have central obesity and diabetes, they are more difficult to manage than obese diabetes patients. Many obese diabetes patients, they just controlled with just metformin and sitagliptin or metformin, dapagliflozin. They are very well controlled for years together. But if you see a centrally obese patient with a high blood glucose, very often in about 8-9 years time, they go to a basal insulin kind of situation. Actually, they have a more worse metabolism when compared to people with obesity. But obesity has its own risks actually, other risks. But metabolism wise, I think there is no, the body fat percentage and muscle mass is more important for metabolism wise.
The driving force here is insulin resistance, not visceral fat. Chandrika, do you have anything to add to that?
Not exactly, madam. It is just that it is left to the clinicians to educate the lean or the obese girls regarding being left out. We are not leaving them out. So whether it is PMOS or PCOS, the metabolic complications are the same, the pathology is the same, physiology is the same. So we need to see the moment because already some 3-4 girls came. They came and told, madam, PCOS is not there now. It is PMOS. So is my ovary cyst gone? So they have actually reached out. So I told, say, listen, nothing has changed. Only the terminology is changed. See, I feel the main intention of changing this terminology, correct me if I'm wrong, Anant, is that gynecologists, because being the primary physicians in more than 70% of women in India with PCOS, it is a very complex disease to understand. The two-cell theory, however beautifully you explain after the lecture, it will kind of, we feel giddy. So with the hormones. So, and also the time taken by the gynecologist to interview a girl, spend so much time for just one patient, again, that is a challenge. And so that way the gynecs are not, to be very honest, they are not doing the justice in the sense, so many of us, we don't know that how often we should do sugar, whom to do lipid profile, should we screen for OSA, the 100 seminars, still it is not going there. So I feel this PMOS will ease that burden from the gynecs and make them understand that they need to screen for endocrine and metabolic. And even if the patients themselves go to endocrinologist first, we are happy.
Okay, that means you're happy and Dr. Anantram also is very happy.
Yes, he's also happy.
He's happy.
Yeah,
because at least the default they will screen and at least they'll try to get the things right and put them on track because they're more wired for that, and at least the reproductive part I think we can hold. But only thing which is under addressed or unaddressed in this PMOS, PCOS is the mental.
Actually, I feel the easiest part to treat is the reproductive part actually. Ovulation induction drugs are so effective. They are about 80%, 90% effective. So many of them tell me that, my gynecologist has not discussed this with me like that. They'll tell sometimes. Then I tell them that, they have not discussed it with you because it's so easy to treat. It's for them, it's very easy to treat. So if they put you on letrozole or clomiphene, you should just ovulate just like that. I think it's enough for most girls with PCOS. So that's the reason why, they have not discussed so much regarding your condition. But it's more of obesity, what you have, and the future risk of diabetes, hypertension, CVD, and all that. But usually, by the time, and usually what happens, ma'am, for a 20-year-old, even, it's very difficult to understand actually. So one of the reasons why I don't talk too much to younger patients is that they cannot fathom or they cannot understand. Only when they cross 35 years, they are worried about their health actually. So people.
You want to take over the reproductive part too, since it's so easy.
I'll put a clinic next to Anand.
Okay, I know. So the next thing is, now your old PCOS patient, you've diagnosed her in the past, and we all know they take treatment to conceive, they deliver, and then that's the last we see them until they come back with either AUB in the perimenopause or they want one more child. Okay. Now, if a patient in her 40s who was diagnosed with PCOS earlier, now, what investigations will you do for her? Will you assess her for cardiometabolic risk? She is 40. Regardless of age, of course, forget about age, regardless of BMI or presenting complaint, would you do a fatty liver, fibroscan or an abdominal scan for a fatty liver? Tell me, Chandrika, then we'll go to
Madam, Madam, see, what we need to tell our patients is that
we have this PMOS.
Yes.
We need to justify the change in terminology.
Understood.
Not just treat them like PCOS earlier.
Understood. So this PCOS or PMOS, I tell the patient very calmly after speaking to them half an hour that it is an enduring diagnosis. It is not that, it has just come for 3 years and then you get pregnant and then it is over. Because you have got a genetic predisposition for this this condition. So PCOS or PMOS is going to stay with you lifelong. And that is the reason we tell them to particularly follow this lifestyle intervention as much as possible and lifelong. I tell them, see, listen, losing 5 kgs and then getting pregnant or getting regular cycles is not the end point. This is going to trouble you lifelong like this, like any other chronic disease.
Chandrika, at 40 years, what will you do?
Madam, we will tell them every year to screen for their lipid profile because it is a commonest abnormalities. Up to 70% will have one abnormal lipid level, and fasting sugar and oral glucose challenge test. And then this is the two, and get their blood pressure checked every year, and have a watch on their abdomen circumference every year. These are the 4 things which I would tell. And if we clinically suspect a OSA, that is history of snoring and breathing, then that is when the special test will go. Otherwise, routinely, we are not doing fatty liver screening.
Yeah, fatty liver screening is just an abdominal scan in the beginning. Dr. Anantran, can you take over now? Would you do all these tests when a 40-year-old lady with a past history of PCOS comes to you?
Ma'am, whatever Chandrika ma'am told, everything I'll do. In addition, I'll probably do a HbA1c for the patient because HbA1c is what we use for diagnosing. And
would you do an abdominal scan? Because I see that most of my patients, I'm sure everybody has the same inputs, has fatty liver grade 1.
Yes, ma'am. But we take a slightly different approach, ma'am. As far as fatty liver is concerned, we do something called a FIB-4 score.
Yeah.
So we'll check the AST, ALT, and platelet count. So CBC is done as a routine for almost all patients in our clinic. And of course, we'll add a AST and ALT to this. So in addition to lipid profile, AST, ALT, HbA1c, and serum creatinine is also done because if they have hypertension, serum creatinine is actually required. So this is done as a part of routine evaluation. And in fact, all girls with all women with PCOS who come in, we do something called in my clinic, we are doing all these things for all patients actually. So for assess the metabolism. So the FIB-4 score will come, and based on the FIB-4 score, then we will classify those who are at higher risk basically. But FIB-4 score applies to people between 35 and 65. Yes. So This 40-year-old will definitely, if the FIB4 score is high, then we'll send them for the fibroscan.
Okay, fine. Can you just explain to the viewers what a FIB4 score is?
FIB4 score is basically a calculator, online calculator. We can just key in the age of the patient, the AST, the ALT, and the platelet count. So once it's done, we'll get a value. And if the value, I think if it's more than 1.6, I think there is a high chance of liver fibrosis being in the liver. So fatty liver is a very common diagnosis. Almost 80% of obese patients will have some amount of fat in the liver. And if you take with the lower degrees of obesity as well, there will be some amount of fatty liver, say 50%, 60%, the lower degrees of obesity, say, and even lean patients, even apparently lean patients who are having metabolic like PCOS, girls with PCOS, lean PCOS, if you take, there can be fatty liver, significant amount of fatty liver. But the fatty liver doesn't tell us, the ultrasound detected fat does not tell whether there is inflammation or fibrosis. Actually, it just says that there is fat storage. The fibroscan, what we have, it's a special device, fibroelastography. It will detect the amount of fibrosis that is there in the liver, and that is a more accurate way to assess whether there is a advancing liver disease or advancing chronic liver disease due to liver fibrosis. And this especially is important because now we have agents to reverse the liver fibrosis. So we have resmetirom, and we also have GLP-1 agonists. Both have been shown to work with varying efficacy, actually. So
Thank you so much. So because fatty liver is becoming a big, especially metabolically, so dysfunction, steatotic
it has
liver.
also got a new name, MASLD. No,
MASLD. That's become quite a big issue nowadays. Okay, Chandrika.
Yes, madam.
Women often, we are coming to the end of our session, Srimati, so don't worry. Women often report that anxiety, depression, body image concerns, a whole lot of them, and reduced self-esteem affect them more than the metabolic abnormalities. We all know our people are not bothered, whether they're going to have some metabolic problems, say, like MSLD, but they're more worried, whether about their self-esteem, their body image, and things like that.
Yes,
Does the PMS terminology adequately capture the psychological burden of the condition?
Unfortunately, no, madam. Either PCOS or nor PMOS addresses or hints at any kind of a mental health issue, which is unfortunately much more common than the metabolic problems. Insulin resistance is the commonest metabolic problem, but apart from that, that impaired glucose tolerance diabetes is only around 16% or 10%, whereas depression is there almost up to 80%, and anxiety around 68%, and body image very common, and psychosexual disorders and sleep disturbances. So unfortunately, neither of these terminologies is addressing that.
Absolutely. So 10 years from now, what outcomes would convince you that changing the name from PCOS to PMOS was worthwhile? Earlier diagnosis, better metabolic screening, reduced stigma, or improved quality of life, and more research funding. I request both of you to give your opinion on this.
I would be very happy if more and more women with PCOS are screened metabolically regularly and annually. If that awareness comes, apart from all the other small issues what they have eventually in their life, but then metabolic is the one which hits them for a long term. So I would think that after 10 years, PMOS change terminology will result in better metabolic screening and more preventive disease because it is an enduring diagnosis.
Thank you. Dr. Anantaram, what is your say on it?
I think, if patients become more aware of the condition, that itself is half the problem one, actually. So I can see that in my practice even. So when overall the awareness improves, so earlier I had trouble convincing patients to take medication for diabetes when I started my practice about 14 years ago. So people will ask whether I need to take medication for diabetes or hypertension. Now, nobody questions the fact that they need to take medication for diabetes or hypertension, and these are chronic in nature. So there's an acceptance. So this is
your convincing power has improved.
No, I don't think it's because of my convincing power. It's the awareness of the public also. I'm talking about youngsters in their early 20s. So I have lot of self-administered youngsters below 25 years of age who come and take prescription for Mounjaro, Ozempic and all. They'll come, they'll tell that I'm struggling with my obesity. I want to take this and all. They're very aware. The newer generation is highly educated, unlike the previous generations. It's much more easier. I believe that I had done my degree 15 years too early, actually. Now I'm ready. Now my customers are ready. So I feel that my future is secure. So I don't have to worry too much, actually. So
You are also taking over the reproductive problems.
no, ma'am.
Somehow we will
I
hold
usually
that
stop all
information
of that.
from Anant.
No.
So anyway, thank you, both of you. Both our esteemed
Yeah.
faculty have come out with very valid points in trying to unravel this conundrum. We as clinicians were always aware of the metabolic fallouts of PCOS or PMOS. This fresh coat of paint on an old idea is principally to increase the awareness among patients so that they will follow lifestyle modifications and mitigate the inherent risks. The other thing is that Rotterdam's criteria for the diagnosis of PCOS will no longer hold good. Like how Chandrika said, we need to add some metabolic elements also to it. So we have to wait till that comes out. And thank you, Srimati, for making us part of this event. I thoroughly enjoyed being with you all. Thank you, Dr. Chandrika and Dr. Anantara.
Thank you so much.
Thank you, ma'am.
Thank you, ma'am. Thank you, Jyotika, ma'am. I think there was only no questions. I think only one comment again towards Anantharam, sir. Not easy, sir, to manage anovulation. I think you've stirred a hornet's nest there.
Wants to dissuade him.
Yeah.
Yes.
No.
At least
No,
hopefully
because
trying
I'm
to
convinced.
dissuade him.
No. I think what I meant to say was you people make it look easy. So
Ma'am, he knows how to speak, no, ma'am. That's what you said, no, ma'am. His convincing power.
We don't want infiltrators.
Yeah.
So,
Thank you, ma'am.
Thank you so much. Thank you.
So,
Any
yeah.
consent do you take before giving semaglutide?
Sir,
Anantharam, sir.
consent means I explained to them, what are the side effects with the semaglutide. So, but even there is no anything to say that there is a very severe side effects associated with semaglutide. Even pancreatitis risk also is not elevated in many studies. There's the eye problem that it's also overblown. We really are now many papers are saying that there may be no increase in risk as well. So the common side effects are nausea, vomiting, and a small section of patients who have severe nausea, vomiting, they do go to the hospital. There is no doubt about it. But the vast majority, but that applies to all other drugs. When we use drugs for treating diabetes, even drugs which we use to treat diabetes used to land patients in the hospital. Even sulfonylurea, hypoglycemia, people used to get admitted. So in that context, I don't think it's a worse drug, and we do explain everything to the patient. But there is no consent form or anything which we take. It's just a oral. It's like in any other drug what we are using. Yeah.
Implied consent.
So what is the
So-
youngest age you will give, sir?
Ma'am, generally above 18, I'm giving semaglutide. Though liraglutide can be used below 18 also. There is a label which we can use liraglutide. And I think some research is also going for semaglutide below 18. But generally what happens is in children, we do give a trial of lifestyle modification, and we reserve it for extremely obese children. We do use the drug actually. So where there is a lot of difficulty. I currently have a patient who's 160 kilos who came to me as a child at the age of 16. So, and I started him on Orlistat. He didn't respond. So these are extreme patients actually. They may have mostly some kind of genetic mutation which is causing the obesity. So such patients are there. So, and such patients would be candidates. I mean, had semaglutide been available at that time, 10 years ago, I would have definitely given it to him. I'm starting it now at this age of 24. So he's about 160 kilos or something, and he's responding well to that drug. Yeah.
But he will lose only
Another
about
question.
A question, Dr. Srimati, can I ask?
Yeah, ma'am. Yes, ma'am. Yes,
Yeah,
ma'am.
thank you very much for that insightful talk. Sir Anantaraman, how long can we use this drug, semaglutide? Once we initiate with the patient, and what is the kind of response that you tailor to, and how long can we given? When do you
Ma'am,
call
in
it off as it
non-diabetic,
is not responsive?
yeah, ma'am, ma'am, the response rate is very high. There will be only about 2 or 3% of patients where we start the drug and there is no response, that is zero response, which is excellent. So around, if you look at the number of people who are giving a 5% weight loss, almost 70% of patients, 70 to 80% of patients will experience a 5% weight loss, which is very good. And if you look at number of people who are getting a 10% weight loss, that will be around 50%. So half your patients will lose at least 10% of the weight. That's how to look at it. And the more the number of complications associated with obesity, less the weight loss actually. Okay. So if you have obesity with PCOS, the weight loss effect will be a little less. If it is obesity with type 2 diabetes, definitely less. If with diabetes, it's obesity, hypertension, diabetes, and older age. And with the older age also, the response is less actually. That's how I explain to patients. In a young patient who's not having any other problems, not PCOS, not diabetes, the response is the best actually. It's only purely obesity.
So how much time minimum do you wait to get a response?
Ma'am, within the first month, you can notice the result.
Okay. And for how long do you sustain?
With semaglutide, with Mounjaro, the results are very fast actually. So the Mounjaro gives almost twice as fast the response as semaglutide. And within 2 months, about 8% weight loss is seen in Mounjaro. And within 2 months, about 6-7% weight loss is seen with semaglutide. Yeah.
Thank
So
you.
the response is immediate. So if someone doesn't respond, then they are likely to respond less to even the maximum doses. But when we escalate the dose, they are likely to lose weight. They are likely to lose weight. With the higher doses of semaglutide, patients do lose about 10% weight. Yeah.
There's a question for Chandrika. In PCOS, when do you think of giving metformin? Chandrika? Can you hear it?
I'm muted.
Yeah,
muted.
I was muted. Sorry.
Yeah.
So basically, it's simple, madam. Whenever they are obese, whenever there is a metabolic issue, if the cycles are regular, if the lifestyle modifications have failed, that is when we can give metformin till the target is being 5%, minimum 5 to 10% of weight loss. So we can introduce metformin when the lifestyle modifications have failed, and our main concern is the overweight or the metabolic issues rather than the irregular cycles. That is when I would give. I would give how long I would give till they lose weight. I mean, I tell them, see, listen, you take this till you lose weight, you keep this as a target 3 months, 6 months. Only after you lose so much, that is when I'm going to taper down and stop it.
There is one more question for Anantram, sir. What is the worst complication you have seen till now? I think with semaglutide.
Worst complication is hospitalization and gastroparesis. I have not seen even pancreatitis. So what had happened was many patients we initiate and the patients want to take Ribulsus actually. It is not with the injectable semaglutide. It is more with the older Ribulsus. Patient was on 14 milligram Ribulsus. I warned the patient that it can cause gastroparesis, nausea, vomiting. If it is very severe, you stop it. But patient don't want to stop it because they are afraid that if they stop it, they'll regain the weight. So patient had severe nausea, vomiting, and had underwent endoscopy. Then finally, the gastroenterologist stopped the drug actually. So, and she never brought it to our attention. And she's not even from Bangalore actually. She's from a smaller town. She basically wanted weight loss anyway. But I think we changed. I think we stopped her of the drug, and then I gave her a break. And then I don't know whether I started her on tirzepatide or not. Maybe a smaller dose of tirzepatide I might have tried. And typically, the GI side effects used to be worse with the oral drug rather than the injectable.
So in your experience with the self-injection, are there people who jump the dose? Say 0.25 to 0.5? Do they
I strictly want them not to do that, ma'am, but they have done it in the past. Patients have done it in the past. They are this thing. So, but I counsel them. I tell them that it's important that you lose weight. And it's a marathon or not a 100-meter race, actually.
I know.
I think there are no more questions here. Even gallstones you have not come across, huh?
Gallstone.
Yeah, gallstones, operation for gallstone is there. It's an association with the semaglutide, but it's typically handled by the patient easily. So the hospitalization, sudden acute hospitalization is what concerns me. So 1 or 2 patients of mine who've been on semaglutide and all, they've got operated for gallstone disease actually. But the thing is, even otherwise, gallstone complications do occur. It's more of an association. We don't know whether it's causal actually.
Do you do an abdominal scan before starting?
But no, ma'am. I'm not doing any investigation before starting. Not amylase, lipase, not retina examination. Look at the crowding of the retina and all that. I don't do any testing because that's not because as per the label and as per the clinical trials, none of it was done. So in all obesity patients, they just check the weight, height, waist circumference, and usual metabolic profile, liver enzymes. They establish that these tests are done to establish the indication rather than establish the safety of the drug. Actually, there is nothing to suggest that there is a safety issue. Yeah.
So
When
thank you.
Anantram is there, whatever the topic he's chosen to talk on, it will go to semaglutide or tirzepatide.
Yes, ma'am. That is the talk
Yeah.
of the
Talk of the
world
town.
now.
Yeah, yeah.
Yeah.
Talk
Because
of the
new
world,
one is also
literally.
coming
Yeah,
up. No, the triple agonist is coming up, so not
Triple
more
agonist is
which
coming.
are coming
Yeah,
up
yeah.
now. So yeah.
Because I remember the first day we discussed our GL regarding incretins was during my MD seminar. I still remember giving it in 2006, 2004 or 5. The 2007 is when the first GLP-1 agonist came into the market. It's called exenatide, Byetta. So we have been using it from that generation actually. So it's a great fortune for us that we found a drug or the drug was found in our specialty which we can use actually.
It came first for diabetes. And
Diabetes.
later they
Yeah,
started
yeah,
using
yeah,
it for
It's
obesity.
called Byetta. So it was used twice daily. It used to only control the blood glucose, give a modest weight loss of maybe a few kilos. And then came the next generation was liraglutide, which is a daily injection. So the game changer was actually the semaglutide and the tirzepatide. Yeah, last 6 years or 7 years have been wonderful.
Thank you, ma'am. Thank you, sir. Ma'am, shall we end the meeting, ma'am, with Rashri ma'am's permission? I think Shobha Bembelgi, ma'am, Arun, for vote of thanks, no?
I think you
Rashri
can.
ma'am, any concluding remarks, ma'am? Rashri ma'am, any concluding remarks, ma'am?
I strongly believe that now, we need to focus more on these newer molecules that we are having, and there's so much of interest generated. It's just that we don't need to end up in the wrong hands and doing the wrong kind of message. Now everybody seems to be getting aware of semaglutide, and then the investors have also started investing more in these drugs. Companies who are producing these drugs, that is the kind of market value it has gained. But I would request Srimati and Rashmi that let us have a more extensive discussion about this molecule in the various applications, not only to PMOS and PCOS that rightly as Sir said that I think it initiated with diabetes, and now it's found its application so much so that every aspect can be touched upon. More so, what is the interest which has generated, especially for me, was that the striking benefit that it gives on the long-term cardiovascular benefit. Now, apart from reducing the weight, how remarkable this benefit is that, the incidence of stroke and MIs and all that are reduced by using this drug. So I think more needs to be understood and more justified application about semaglutide and other such molecules which are now new. Thank you so much for touching upon all the aspects, and have a good evening and good night.
Thank you. So with that, I will give the vote of thanks, ma'am. I think Shobha Bembelgi ma'am is not there. So thank you very much, Kosa, for giving us opportunity. Rashri ma'am for giving us opportunity. Of course, Jyotika ma'am for behind me at every step. And Chandrika ma'am, Anantraman sir for joining, Rashmi for having given the capsule and being again with me throughout the whole journey, not just here and journey in Kasoga and BSOG. And I also like to thank Shobha Gudi ma'am, the MG Remed sir for joining, all the patrons, all the office bearers, and of course Arun for being the backbone, and all the delegates who have joined this program. We'll hopefully come soon, as ma'am suggested, maybe with GLP analogs. Maybe we have Anantram sir whom we have found start for Kosoga. So maybe we will have to trouble you again and bring you back for another interesting webinar where we can probably have an extensive discussion on GLP. Ma'am.
Take trouble. He'll be happy to join.
Yes, ma'am. Yes. And to make comments for his comment on OI. Thank you very
Okay.
much, Ram. Thank you, sir. Thank you, everybody.
Okay.
Thank you.
Thank you.
Thank
Good
you.
night.
Thank
Good
you.
night, everybody. Good
Actually,
night.
Thank
a
you, ma'am.
best academician is a best clinician as well. So that goes as a corollary, you know. Thank you so much for
Thank you,
being
ma'am.
Thank
Chandrika,
you.